Welcome to the fun session. You're in the right place for regulations and accreditation standards. I hope you enjoyed your box lunch. And my objectives are to help explain the CDC Core Elements for Antimicrobial Stewardship, since they make up a large part of the regulations and accreditation standards. I'm going to look at both Joint Commission requirements and the Critical Access Hospital mandate from the Office of the Rural Health Policy. Now, I was asked to pinch hit on this presentation a few weeks ago when Dr. Srinivasan learned that he wasn't going to be able to stay for the afternoon, and it wasn't until just this week that he realized he couldn't do the morning presentation in person either. But Christy Cooper from Vizient helped me out with some slides that were presented earlier this year on regulations, and Dr. Srinivasan had already started the presentation and gave me a few slides at the end on outpatient stewardship as well. This was a table that Vizient developed for their members to compare the regulations and accreditation standards. The Joint Commission, most of the larger acute care hospitals are accredited under that, and you're familiar with that. And the smaller hospitals don't always follow Joint Commission, but they still have Medicare requirements to follow. As Dr. Srinivasan alluded to, the CMS rule was printed in 2016. It was never finalized after the administration change in Washington, but Medicare still has implemented a lot of those same elements in their quality improvement program, the Medicare Beneficiary Quality Improvement Program, making it essentially required for critical access hospitals if they want to receive funding from Medicare, which was what keeps them open and running in the first place. Nursing homes, they're in the room next door. Some of you may still service nursing homes, and especially in smaller facilities, you have to do both and have two different hats. You know, they've had the rules from Medicare in place that were signed. They began reviewing those in 2017. They did delay the enforcement of those, so there are state surveyors on behalf of Medicare evaluating nursing home practices and stewardship and giving citations, but they're not penalties yet, but they're remarks that this could be improved. So they're really leading the way, and with a lot less resources and knowledge of what is best practice in nursing homes, but that's great, they're being pioneers as well. Outpatient clinics, ambulatory care is another frontier, which has been the Wild West for stewardship for a lot of years. The CDC is paying a lot of attention to that. They've always tracked resistance and antibiotic prescribing, and for the most part, those numbers have remained flat for appropriateness. We're hoping to move the needle in the next few years with new Medicare incentive payment systems that Dr. Srinivasan alluded to, and I'll explain those more at the end. Joint Commission Medication Management Standard 9.0101 is what hospitals have been looking at for the last year, because these went live January 1st, 2017. They're essentially mirroring the core elements from CDC, that hospitals need to show that antimicrobial stewardship is a priority for their facility. They need to be educating licensed and independent practitioners that have privileges at that hospital upon hire and annually thereafter. So most facilities are doing this through some kind of credentialing process that they have to view some slides or read a little bit, sign off that they know at least what the term is in case Joint Commission asks. You know, we'd like to do much more than that, but especially at larger facilities like ours, there's thousands of different providers, so trying to capture them all every year has been a challenge. Another area that has been difficult, and even with good intentions, is to educate patients and their family members that are in the hospital acutely ill, and giving them education on antibiotic use when their loved one's in the ICU proved to be especially difficult. So the Joint Commission backed off of that requirement last fall. They removed that as an essential element of performance from their standard. So education, still needs to be done in some capacity to patients, most likely at the discharge stage, but they're not zeroing in on antibiotics in particular. It's really all medicine have to have some cursory education before the patient leaves the hospital. As mentioned earlier, too, the stewardship program should have a multidisciplinary team. When available, an ID physician should be a part of that, although they do acknowledge not all facilities are going to have them. The 7 core elements are outlined as their own element of performance, and we'll go over those in more detail. But several of them are redundant in the standard because tracking, action, reporting, those are so important that they have their own questions in the Joint Commission survey. Now that this standard has been out for over a year, the Joint Commission is starting to report back on what are hospitals being cited on. So last fall at the Infectious Disease Society meeting, Dan Baker from Joint Commission presented data on how many hospitals were surveyed and cited. Turns out to be about 4% are getting this citation for not having these stewardship elements. By far the most common is not having those physicians and independent practitioners having some type of education and being able to check off on that. So we use an electronic education system for our competencies, so similar to bloodborne pathogen training and infection control. Everybody looks forward to those every year. So now the physicians are having to do those, and we've incorporated some stewardship slides in. How effective that is, I can't really say, or probably not super effective at changing practice, but at least bringing awareness to it. And for us, we stick in our website at Nebraska Medicine, what are the resources, some of the hot topics that we're going to be addressing, so they shouldn't be as surprised when we call them and tell them this is a priority. The others, like lack of a multidisciplinary team, these are things I think once they're addressed, they should be fairly easy to fix once you have somebody on your committee. Getting them participate is always the hard part, naming somebody from all of these different areas, getting them together. The education piece was the second leading citation, so that's now gone. And the other one that's fairly big is the core elements, so being able to check off that you're doing something in each of those. The future direction, and Dr. Srinivasan alluded to working with the Joint Commission to really help drive this, and what should the Joint Commission be asking? Well, we don't all know what best practice in stewardship is. It varies based on different facilities. So we're really looking at data and research. They are funding studies. We know that doing something helps antibiotic use. Decreasing antibiotic use helps resistance, but we don't know quite what the best ways to do that are. Now, critical access hospitals, even if you're not Joint Commission accredited, I mentioned you do have to implement the core elements, and that is by the year 2020. So this is one of the objectives and learning assessment questions is, how long do you have? It's a 4-year lead-in period, so right now you need to be working on it as of 2018, and August 31st, 2022 is the point where then citations or really funding will start to be withheld. And this is necessary for that flex grant funding that makes critical access hospitals, they're reimbursed differently, and this is really that incentive that Medicare gives to follow best practices. So there's several different resources out there to help you along the way. The state flex coordinators, I've added the website in for the state of Nebraska, the state DHHS, the HAI team, and antimicrobial resistance resources. So that was Dr. Tierney and Padati and Nebraska ASAP. The program that is putting this on at the Med Center primarily drives, we're funded by CDC and the state to help be a resource for the whole community. And then the Quality Improvement Organization, the QIN, that's funded by Medicare. So that's the Great Plains organization. I saw Tammy Bauman here earlier. They're doing a lot, especially in emergency departments and outpatient clinics. So there are resources around to help. So if you are at a critical access hospital and are wondering, what should I be doing this year, the expectation is that you will have at least signed up for that NHSN, the National Healthcare Safety Network. That's what Dr. Srinivasan was talking about when he was showing the slides of how many hospitals have the core elements, and then eventually submitting healthcare-associated infection data, antimicrobial use data. There's different steps and modules within that. Stewardship falls into the patient safety category, and you've heard at this meeting already, that's really what's driving stewardship is patient safety, not just using less antibiotics to save money, but to prevent harm from these antibiotics. So the questions are a lot about infection control practices, but also testing. How are you testing the C. diff? Is it PCR only, or are you doing a screening test for the antigen, like Dr. Diekma mentioned? Because how your data is analyzed is going to vary based on that testing method. And then there are specific questions on those CDC core elements. There was a webinar earlier this year on the Federal Office of Rural Health Policy website. If you're interested, you can look at that. CDC and DHHS teamed up for that to show how to get signed up and how to report. So these are the core elements. You've probably heard them and seen them by now. You're interested enough to come to this program. So you follow these 7 core elements, and your patients will be smiling in their hospital beds with makeup on and everything. Now, first off is that leadership commitment. So my goal here is to list what the CDC is recommending as examples and tell you, some ways that you can help meet it. You do not have to meet every single one of these bullet points to feel like you've achieved that element. But formal statements are one of the easiest way to open your binder when you're getting surveyed and say, yes, stewardship is a priority. Our CEO signed off on it. Job descriptions for medical directors, pharmacists, is another good way to show that not only do they say it's a priority, but they're funding it, and that gives us time to work on it. Anybody that does stewardship will say you can always do more. You need more time, more resources, because there's always more antibiotics and more bacteria out there, but at least having something. The different departments leadership can help to arrange some of those surgery departments or people that are outliers that you really don't have relationships with. So showing that they're also being pulled in, that multidisciplinary team. Training and education, like the program you're at today, keep the program, throw it in your binder for your regulatory survey and say, hey, I was given time to go to this, and the state helped keep the cost low through our grant funds from CDC. The accountability and drug expertise are really having those leaders down on paper, not having a job description, or at least in at least one line in that contract. If it's a medical director, if you're paying them, you get what you pay for. So usually stewardship will pay for itself, but they have to put some funding into it in the beginning to be able to show results. If you don't pay a medical director, they're not going to do much for you. It's going to be hard to gain traction. Having a strong pharmacy leader really drives most programs, but when push comes to shove, it helps to have a medical director that's willing to talk peer-to-peer and really get physicians to understand where they're coming from. So it's not a pharmacy versus a prescriber battle. Also, we've heard from infection prevention and lab. Quality improvement is really important. In the CMS rules, it actually says stewardship should report to the quality department. Whether they're housed there or not is really up to your individual hospitals, but there needs to be some type of reporting mechanism, usually through infection prevention, and that's where they're being accountable to. And it really fits into that patient safety component. It also helps get away from some of the pharmacy goals of reducing the budget, simply using the cheapest antibiotics to save money, to say we're really trying to prevent C. diff, and it's not all about the drug budget. IT is another big one that sometimes gets overlooked when you're starting a program. Medicare says the average hospital is 126 beds across the country. That's the mean. And for that size hospital, they should have about 0.25 pharmacist FTE, 0.1 physician, and 0.05 or 5% of information technology personnel assigned, so that they can help build reports, put in EHR alerts or diagnosis, fields, duration limits. And then nurses, we heard about their role at the bedside as well as being important advocates. Action is one of the biggest elements within the core elements. Dr. Van Schoeneveld's going to talk for a whole hour on different strategies for action. So I've just listed a few. There can be broad categories. Having the dose, of course, that's something Joint Commission wants anyway, not just these open-ended orders. We've moved to having duration as a mandatory field. Once prescribers get used to this, having indications as mandatory. With us, we get new residents every year, so training them really helps drive it. But it's kind of silly to think back, and many of you probably still don't have that luxury of you're seeing antibiotic orders and you really don't know what it's for or how long it's going to be continued. You're trying to monitor this day 6 of 7. Okay, they're supposed to stop tomorrow. There's a lot of extra work that goes into that, looking up what's in the notes and counting the days, especially when doses are changed, trying to keep track of that. EHRs can help a lot with that, but take some time to get set up right in the first place. And then just the mentality of doctors having to justify themselves. When I was in Illinois and we were implementing this, we'd get indications of infection or leukocytosis, and that didn't really help us much in our stewardship. Fever was always a good one too. So you don't have to implement all of these at once is another key point. At least have something that you're working on when you're surveyed. That's the most important part, is to have a plan and work towards goals. Don't try to implement all of this at once or you'll be overwhelmed, and your prescribers will be overwhelmed as you're trying to educate them and contact them. Tracking and reporting go hand in hand. If you have syndrome-specific guidelines, community-acquired pneumonia, something as simple as an order set is going to help meet the requirement that first visit. Something where you're guiding them to those formulary agents that you have. I mean, most of the time we think of that as just the way the hospital operates. We can't keep every drug, every type of drug and every dose. But then also, does anybody use it? Being able to say, at least it was used this many times, and then they were picking the first line agents, do a small audit, have that information available for the surveyors, that it's important to track that and that you care. And if it's not being followed, you have to have a plan of what did you do about it. You can't just say, oh, they use it, our order set about half the time, and leave it at that. You have to say, well, we educated them that it was available, or we made this formulary change and we put it in their newsletter. Tracking resistance is something that infection prevention is pretty good at, so you probably already have resources for that. How many hospital-acquired infections do you have? Like Kate Tyner was saying, is MRSA a problem? Do you see it transmitted? Do you have C. diff? It's sometimes hard to know how much you have and until you start to track the rate, so either by hospital admissions or patient days, and the state can help you with comparing too. There are some benchmarks, but it is different based on the size of your hospital and the acuity level of your patients. Ideally, you have brought all these multidisciplinary leaders together. You should have a meeting, document it with some minutes. We do a lot of email. When we have new guidance, we do virtual meetings where we get things approved. We have made it a little more formal lately, that where we're getting antibiotic use data back from the CDC, and we want to be able to explain that and share it with our providers. We can also get feedback from them a little bit better in person when you're asking more open-ended questions like, why do you use vancomycin and Zosyn in every patient? You get the people that come to the table that are willing to talk. The ones that don't want to talk don't come, but you start to find out, how do you use it? How do you order it? Dr. Van will go more into that, but do you use the order sets or not? And why not? The ones that are honest and say, oh, there's too much on it, or the ED doesn't want it because it has every 8-hour dosing and they only want to give a one-time dose. You learn things that make sense to them but not necessarily to you. And make sure this reaches your C-suite, your CEO, your chief medical officer at least once a year. which helps with that quality reporting. They have the ear of the CEO usually, so making sure they find out the good work. Maybe not everything you did all year, but the highlights of what did you accomplish tells them where their money's going and that it's worthwhile when you ask for more money to get more positions or more time later. Education, I mentioned, things like newsletters, going to in-services or grand rounds if you have one. The antibiogram is a good opportunity for this. Every year, the lab should be helping make that antibiogram. Joint Commission has said, at least right now, developing an antibiogram and sharing it with providers counts as education. So you might be doing that already. Again, I don't know how effective it is unless they know how to use it. Really try to highlight 2 or 3 things that you're seeing a trend in resistance to ceftriaxone or fluoroquinolones in E. coli. We have an order set with different options. You don't need to use Levaquin in every patient that comes in the door. That kind of education goes a long way at the survey, and have it documented. Maybe just 5 slides that you went through with them at a breakfast, but print those off and put it in your binder or your virtual folder that you keep your Joint Commission and accreditation stuff in. If you're overwhelmed by all these different options, the CDC does have a checklist of the core elements with a lot of what I've talked about. Again, you don't have to say yes to every one of these, but make sure you have a yes in at least one of each of the categories so that you can say you're working at it and you have a plan. And once you get to that point, your patients will be smiling with their bright white teeth again. If you work in a critical access hospital, they have their own document, this nice, pretty blue sky. It's really the same elements, but it's a smaller scale. Take advantage of that smaller scale. You know the people at your facility. You see them every day. The nurses are especially important here. They're seeing the prescribers. They know when they come through. They know some of the practices, when to catch them. But also share it with your C-suite, your CEO, your chief medical officer. They're usually a lot more accessible than they are at a giant medical center. So make sure they understand those good things you're doing and focus on the common things: community-acquired pneumonia, urinary tract infections, and cellulitis, skin infections. That's what you're using probably 3/4 of your antibiotics for, if not more. So pick one of those, start with it as an initiative. The outpatient core elements are a little bit smaller. There's less parts to it. It's also a little bit easier to attribute prescribing. In our hospital, with all the residents and specialists giving recommendations, it's hard to track down who's really responsible for that antibiotic order. In smaller hospitals and in clinics, it's one prescriber. They have their name on that order, and you're pretty sure that they're responsible for it. So you can track that better. They have, in their core elements, just 4 main points: that leadership commitment, that action with some kind of policy or practice, the tracking and reporting are combined, and then education and expertise together. Again, this is not technically required, but CMS has come up with a new payment model that highly incentivizes this. So it's basically required as we go forward in the next few years to be doing something. And also clinics, if the hospital is Joint Commission accredited, clinics have typically fallen outside of that, but our system recently changed to be hospital-based outpatient departments at each of the clinics. And that was having to do with some of the 340B pricing rules to be able to take advantage of reimbursement. But we also realized now we're going to be surveyed under the Joint Commission standards, even at our clinics. And they happen to be coming back again this summer to check up on us. So I've been making my binder lately and preparing it, getting the hospital-based stuff that we had provided updated, and now putting some more clinic material in. And Dr. Marcelin is going to be talking about that more later. Again, quality is a difficult thing to measure. Everybody knows you want to have good prescribing, but what does good prescribing look like? So there's a few conditions that the CDC has really singled out, that these are mainly viral illnesses and we want to avoid antibiotics. or these are bacterial illnesses that only require narrower spectrum antibiotics. So is it appropriate to prescribe, and if so, was a narrow spectrum antibiotic prescribed? This started 5 to 10 years ago with the HEDIS measures, which stands for Healthcare Effectiveness Data and Information Set. It also is part of meaningful use, if you're familiar with that term. It's part of the EHR, electronic record incentives. The HEDIS measures are used by about 90% of insurance companies to audit data, either through surveys, some chart reviews, but mainly a lot of insurance claims where you can match up a single diagnosis in an outpatient visit with an antibiotic. In pediatrics, this was testing for strep throat, whether that was done or not before antibiotics were prescribed, and hopefully if it was positive, there was an antibiotic, and if it was negative, there was not an antibiotic. With general respiratory tract infections, this could be a variety of different illnesses, but things like otitis media, whether amoxicillin was given as a narrower spectrum antibiotic. In adults, it was mainly focused on bronchitis and avoiding antibiotics. In this case, in adults, it's almost always viral. So some of the numbers that this was, Dr. Srinivasan had already prepared this slide. He had 2009 to 2012 here for those 3 HEDIS measures. And you can see we haven't made a whole lot of progress from 2009 to 12. It stayed about 80%, 85% in pediatrics. And then with adults, a higher number should be good. This is avoiding antibiotics in a viral illness. Only about 20% of the time do all of these healthcare claims show that an antibiotic was avoided. So bronchitis generally leads to antibiotics. You say, oh, in the last 5 years, there has been all of this attention. Maybe it's gotten better. So I went to the National Committee for Quality Assurance reports this data. And here's over 10 years worth of data showing we're still at about 30% appropriateness. And looking back to 2006, it was still about 30%. So we have not moved this at all. So Medicare's plan to fix this, and they're the government, right? They're here to help. So they have combined 3 different programs that have existed over the years. The quality reporting system, the value-based medicine, and the EHR incentive program, that's the meaningful use, all into one program, the quality payment program, which is called MIPS, the merit-based incentive payment system, or you could be in more of an ACO model, the advanced practice models and the patient-centered medical homes. So they're trying to simplify it, but there's already 2 different avenues to go down. I'm just going to talk about MIPS, and that's a little bit simpler and will help you learn some of the changes that are occurring. Or in the old days, physicians got paid for seeing as many patients as possible during the day, and that was the incentive, was quantity, not quality. So Medicare said, maybe we want them to actually be doing the right thing and not just seeing as many patients as possible. So they're going to adjust that fee schedule based on these quality criteria. For the first 3 years of the program that started last year, that was weighted 60% on quality and 0% cost. So that's looking at the population that's attributable to them, and did they provide cost-effective care in addition to quality care based on these handful of measures where it's a little bit more black and white what should be done. Of course, there's still a lot of gray areas in medicine. The meaningful use criteria, like using the EHR, is now in the advancing care transformation, and the improvement activities is what was mentioned earlier, where having a stewardship program in your clinic falls into play. So in that first column, that's the quality measures right now are 60%, and in 3 years, those will go down to 30%, and the cost of care will be weighted at 30%. This is where the HEDIS measures fall in, and they've added in sinusitis and the narrow spectrum antibiotics, either amoxicillin or Augmentin, basically saying not giving fluoroquinolones and not giving Z-Pak are the incentives here. And the stewardship program fall into that improvement activities. So in conclusion, I stole Dr. Srinivasan's line too about it's not whether or if you start a stewardship program, it's how do you start it. So what can you do and how do you continue it? The core elements are a nice blueprint. You do not have to have every single element in every example, but at least try to get one in every category in the next year or so. If you're part of Joint Commission, you've got your own standards, but they generally mirror those core elements. And if you're a critical access hospital, talk to the people at your hospital that deal with Medicare funding. They're going to be really familiar with this. The FLEX program is pretty common language in those hospitals. And if you have a clinic associated with your hospital, you start to ask them what they're doing. They probably have some of these measures already. The HEDIS measures have been around a while, and insurance companies will feed those back to providers if they're willing to listen. So that concludes my presentation, and I'll open the floor to questions at this time.